Assalamu'alaykum, and the first lecture event 2024. Today we have gathered here for insightful discussion on a topic of immense importance in the field of healthcare for prenatal testing for rare disease. I am Mitra Nobani, a second semester student in Master of Science Biomedical program specializing in genetic counseling and DMC for this event. Before we delve into integral world of prenatal testing, let me extend a warm welcome to each and every one of you. Your presence is truly appreciated, and your interest in advancing knowledge in the realm of biomedicine is commendable. We are honored on behalf of Director of Postgraduate Skill of your YRC University, Professor Dr. Chandra Yoga Aditama, the Dean of Faculty of Magister Science Biomedical YRC University, Dr. Ndaru Andri Damayanti, Head of Genomic Genetic Research and Center and Head of Genetic Counseling, Department of the Master of Science in Biomedicine at YRC University, Professor Dr. Sultana M. Hafaraz, our guest and keynote speaker from Illumina, Katie Batts Ali, Pandu Bayasan's team, expertise, scholar, and all the participants in the field of biomedicines. Your expertise and contribution are invaluable, and we are grateful for your presence among us. So, ladies and gentlemen, without further ado, let us start our guest lecture event by welcoming our Director of Postgraduate School of YRC University to deliver his opening remarks. Please welcome Professor Dr. Chandra Yoga Aditama online ya, Prof. Yeah, to give his opening remarks.
Baik, terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Okay, so just to check whether sound and picture is clear. So, selamat pagi, very good morning to all of you, and very welcome to the YRC University for this morning lecture. I know we face the quote unquote very popular traffic jam of Jakarta. So that's what we have, we experience every day. But nevertheless, this is a very important event for three reasons. Number one, as we all know that next week on the 29th of February, we will kind of celebrate the World Rare Disease Day. I know this is a rare occasion. Not only the disease is rare, but the occasion itself is rare. It's not so popular yet. So that's why the World Rare Disease Day was established and celebrated every year. I think for Indonesia, we just celebrate, have some activities on World Rare Disease Day, maybe in the last 5 years, as far as I know, not before that. So that's why this event is important, because the Rare Disease Day is a disease, and it affects Indonesian as well as people globally. So we have to make a priority also for the Rare Disease Day. That's the first important thing I want to mention to you. The second thing, of course, will be we are very happy, we are very honored to have Miss Katie Ellis with us. As we know that she is the Australian Certified Genetic Counselor and also Senior Manager Medical Affairs of Illumina. So thank you for Professor Sultana who has contacted that Miss Katie Ellis is with us today, and she will share with us the guest lecture on the non-invasive prenatal diagnosis, NIPT, for screening of rare diseases. This is again a very important topic to be discussed, not only for the student but also for all of us who are handling with biomedical science, especially the genetic counselor aspect. So thank you so much, Ms. Katie Ellis, for your presence this morning. I'm sorry on behalf of the government of Jakarta for the traffic jam once again, and I'm happy that I was informed that after this you will also join the team going to the school. So hopefully, thank you for the meeting today, and hopefully we will contribute. The collaboration between your office and the YRC University will continue in the coming time, not only this time, I'm sure. So certainly, I would like to mention to all of us, the student and all of us, the guest lecture is very important, and the celebration of Rare Disease Day is very important. So let us, attend this meeting, attend this webinar carefully, and then listen to the guest lecture. And later on, if we have time, I don't know how you handle the time because of we are quite late, but I'm sure the discussion will also be very fruitful after the lecture from Ms. Katie Ellis. So by that one, I officially open the webinar, and thank you again for Ms. Katie Ellis, and thank you for all of you who attend the guest lecture in the YARSI University as well as online. Thank you. Assalamu'alaykum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thanks for the opening remarks, Professor Chanda. I would like to ask you to stay on the online. Maybe we have a photo session first. Yes. So please, the all participants, the guest lecture keynote, maybe standing here to have a photo session. Yeah. All participants could take a position. Profesor Chandanya nggak muncul sini. Ya, boleh dibantu? Di ini ya, di pin ya. Ya, dua, satu, dua, tiga. Satu lagi dari fontnya ya, satu, dua, tiga. Okay, Fedis. Thank you. Thanks, Prof. Chandra, for your participant. Yeah. Yeah. So, ladies and gentlemen, it is my pleasure to introduce our esteemed speaker today, Ms. Betty Ellis. With a career spanning over 2 decades at the forefront of healthcare innovation, Ms. Ellis brings a wealth of experience and expertise to our discussion. As a session genetic counselor from 1997 to 2021, Ms. Ellis has dedicated herself to supporting individuals and families and navigating the complexity of genetic information. Her compassionate approach and commitment to empower patients have earned her admiration and respect within the medical community. Currently serving as Senior Manager of Medical Affairs at Illumina since 2021, Ms. Ellis continued to drive an advancement in genomic technology and medical practice. In this role, she plays a pivotal role in shaping strategies and initiatives to enhance patient care and clinical outcomes. Ladies and gentlemen, please join me in giving a round of applause to welcome Ms. Battese Ellis.
Thank you very much, everybody, particularly for your kind patience. We were hoping to be here early, but this is new for me, all of this traffic. You have 250 million more people than my country. So never in my country will I say this is traffic again. It's not the same. Okay. We ready? So I will talk today about NIPT, non-invasive prenatal testing. Thank you. Next slide. And of course, just the disclaimer that I do now work for Illumina and I do hold equity, and Illumina is one of the companies that do NIPT. Next slide, please. And next again. You can go down. So I wanted to first start with a case that this was some years ago. This lady was 37 years old in her second pregnancy. Her first pregnancy had ended in an unexplained miscarriage. She had her ultrasound scan and correct dates, and at just over 10 weeks had NIPT performed. And it was the whole genome sequencing of NIPT. And it showed trisomy 15, an increased chance for trisomy 15. At first, this lady was very upset and angry. She really just wanted a test to find out, was the baby a boy or a girl? She misunderstood why she was having this test done. She said, I didn't know we would find out this information. But in fact, this was in the early days of NIPT when we were looking for more rare chromosomes. And the specialists also questioned, how could this be? Trisomy 15 does not live. She must have had a miscarriage by now. How could this happen? At 12 weeks, the ultrasound was completely fine. We also tested the mother. Maybe this was something with her. No, completely fine. So we kept saying, we're very worried. This is a very true signal for the laboratory, and we're worried about this baby. Finally, they said, okay, we will have an amniocentesis. We want to be sure about what's going on. The ultrasound at 18 weeks, still nothing. This baby looked completely well. But what went on to happen, I think, yes, down. Is it coming? Yes. The amniocentesis showed, yes, really was trisomy 15 in 30% of the baby's cells, but uniparental disomy in all of the cells. So this baby had Angelman syndrome, which is the happy face, the happy puppet is one of the names as well. The children have quite ataxia, so they appear to walk unsteady, like a little bit like a puppet. They are very happy and laugh a lot of the time. So this child had this condition and also trisomy 15 in 30% of her cells. Still, the ultrasound was completely fine. Next slide, please. And again, thank you. So just a reminder that in NIPT, it's not just one test. This is quite difficult for us in genetic counselling. There's the common trisomies, trisomy 21, 18, and 13, and most of the NIPT look for this. You can also look for the sex chromosomes, and some countries allow you to report on the sex of the baby. Some countries say you may not, and some countries say you may report if there is a problem like Turner syndrome XO or XXX. There's also genome-wide, and this is what we'll talk about mostly today, looking at all of the chromosomes and also looking at imbalances, deletions or duplications of around 7 megabases. And there are also tiny deletions, microdeletions, and we won't really touch on that today. Down, please. Oops, yes, so this is what we're looking at today and next. So the reminder, of course, the common trisomies, the sensitivity and specificity is very high. 21, the sex chromosomes, and 13 and 18. And next, please. Today, we are talking about when you do NIPT for all of the chromosomes. And next, please. Sometimes the question is, why would you do NIPT for all of the chromosomes? And we know that most pregnancies have no problems. Baby is born with no problems. But about 3% do have malformations or changes. When we look at what those changes are, about 15% are due to chromosome changes. There are single gene disorders like perhaps thalassemia, cystic fibrosis like this in about 10%. There could be a prenatal exposure, maybe a medicine that the mother had, or maybe an exposure to a chemical. There are multifactorial changes, but we still have many that are unknown for why this problem occurred. Next, please. Yeah, and down again. Thank you. So when we look at chorionic villi, back when I started and Prof. Sultana, you could find in the placenta that there were chromosome changes. And in fact, this is what we're able to find on the NIPT, because it is in fact essentially a liquid biopsy, a liquid CVS as it is. So why would we look for the other chromosomes? And it's actually because 28% of the chromosome changes are still found in a pregnancy. And despite what we initially thought, actually they do, you can remain pregnant with these changes. It's not always a miscarriage. Next, please. And what happens in these pregnancies depends on many things. Which chromosome are we talking about? How much genetic information is gained or lost? Is it mosaic? Does the baby have a mix of cells that have standard chromosomes and a mix of cells that have the chromosome change? And exactly what does this gene code for? Next, please. And then next, thank you. And keep clicking. Yeah, thank you. So if we look at the rare chromosome, sometimes they're called RAs or RATs. RATs doesn't sound quite right to me. So they were now done many, many studies because initially the doctors said, this is rare. We don't have to test for this. It doesn't happen very often. We now have multiple papers throughout the world that actually these are quite common. So when we have looked at all of these pregnancies, followed them through the pregnancy to see what happens, about nearly 60% of these are confirmed to be in the fetus itself, the developing baby, or they have an abnormal pregnancy outcome. The abnormal pregnancy outcome can include a miscarriage later than the normal 3 months that we say. It can include the baby dying throughout the pregnancy and being stillborn. There can be multiple congenital changes, so perhaps a cleft lip or cleft palate or a heart malformation. We find fetal growth restriction is quite common as well. So as the pregnancy develops, the baby does not grow very well. And sometimes you might say, oh, this is good for the mother to have a small baby. But in fact, this is not good. The baby it can be very hard for them to survive, and the birth process can be very hard. And also in these pregnancies, they can go into premature labor, which of course has quite risks for the baby. Next, please. And next, there'll be 2, yes. So what was very interesting is the adverse outcomes are seen with many of the chromosomes, not just 1 or 2 of the chromosomes. And often there was no ultrasound changes, and often the biochemistry like PAP-A or beta-HCG, which are hormones we often measure in pregnancy, they were also completely fine. When we look at deletions and duplications, the ones that are 7 megabases and above, we actually find these in over half of the babies. So again, the thought that babies don't have these changes and the pregnancy doesn't keep going is not right. Yes, please. So in another big study, they were looking at how often does this happen? And this is a study that came out of the Netherlands called the Trident study. They've done a very big population screening of NIPT. And they found about 1 in 275 women had an additional finding, not trisomy 21, 18, or 13. When they then followed them through, so first thing to understand is that in the Netherlands, they ask the women, do you want just these 3 common trisomies, or do you want all of the chromosomes? Most of the women, so 75% say, I want as much information as I can, please. And an additional finding was detected in around 0.36% of cases. So not super rare, but not super common. 196 of those were the rare trisomies, so a complete chromosome change, and about 188 of those were smaller changes, and then there were 18 that were very complex profiles. Now, importantly, of those, 77% were pathogenic, so they had a very severe phenotype in the developing baby. The others, so 189 cases, had confined placental mosaicism. So the chromosome change was not in the baby, only in the placenta. And of those, over half had adverse outcomes, like I spoke about. So the positive predictive value, which I'm sure you've heard many times, this means if I have the test and it says there is a problem, what is the chance there really is a problem in the baby? For the rare autosomes, the entire chromosome, it's around 7%. For the partial deletions and duplications, they found around 44% of the time it was in the baby, okay? But remember, Just because it's not in the baby doesn't mean it can't cause a problem to that developing baby. Next, please. So just a quick reminder, I'm sure you have studied this with Prof. Sultana, but at the top here, we have when the embryo is first created, the egg and the sperm come together, they create a ball of cells that divide and multiply. So in the like pink purple color, this is where there is a chromosome change, and in the gray, this is standard chromosomes. So when the ball of cells, the embryo is developing, about 2/3 go to be the placenta, and a third, only 1/3 stay to be the baby. So you can get a combination of what happens. You may find those pinky purpley cells in both the placenta and the baby. This is a true mosaic result. And what happens to the baby depends on exactly where those mosaic cells are. If they're mostly in the skin, you don't usually see a problem. But if they are in the brain or in the heart, then you will see developmental problems. In the middle, you have just the changes, the chromosome changes in the placenta. So your NIPT will be positive. It will say there's a problem here, but your baby has only standard cells, so it will not develop a problem. We do need to watch that pregnancy though. And then in the final slide, you can have the placenta, which has no chromosome changes, but the baby, in fact, has a mix of cells. This one is where NIPT tells you no problem, but actually when the baby's born, you will find a problem. Next, please. So it's important to note, we used to call this false positive, say that the test was wrong, but in fact, it's not wrong. It's just that with NIPT, we recommend maybe an amniocentesis or an ultrasound. This checks the cells just from the baby. It does not check the cells from the placenta. If you check the placenta, then you do find the change. So it's important to call this discordant, not false positive. And as I mentioned, it's very important that we watch these pregnancies closely so that we have the best outcome for the mother and the baby. Next, please. And thank you. So just a reminder, and this is probably something you've studied as well, uniparental disomy does occur in humans. So the very common cases that you might see, and I'm sure Prof. Sultana has told you, is Prader-Willi syndrome, Beckwith-Wiedemann syndrome, Angelman syndrome. Yes, these ring bells. So we know that this does occur. We know that there are some chromosomes that it is important to have the genes and the chromosomes from the father and one copy of those genes and chromosomes from the mother. This is what usually happens. But if a mistake occurs and 2 of the father's chromosomes go in to make that embryo, that baby, then the mother's copy is absent and you will find that the baby may have certain diseases. If the mother's 2 copies go into the egg, then again, you can find particular diseases. It is also possible to get autosomal recessive diseases this way. So if by chance you happen to pass on, say, 2 of the mother's chromosomes and she is a carrier for thalassemia, the baby will actually develop thalassemia major, even though the father is not a carrier. Next, please. And again. So, of course, this can happen either by the egg or the sperm starting with 2 chromosomes instead of just 1, or it can actually go the opposite way where you have no chromosomes, that particular chromosome, say chromosome 15, is not in the egg. And then when the embryo is forming, it realizes, oh, I'm missing a chromosome 15. I need to do something about that. And so it duplicates itself and you end up with 2 of the same chromosome. Next, please. So it's important to know that the confined placental mosaicism is a risk factor for uniparental disomy. And what we see in the child depends on which genes and chromosomes we're looking at and which parent did they come from. And so we do recommend, if you find this, and I'm sure Prof. Sultana has told you about this, there is particular testing you need to do. A carrier type won't show you this. You need to do the particular methylation studies to find. Next, please. So for NIPT, you're actually able to pick up the pregnancies that are at an increased risk of uniparental disomy. So we have found, in fact, uniparental disomy on many of these chromosomes. The American College of Medical Genetics and Genomics does recommend uniparental disomy if you have in the NIPT trisomy 6, 15, 20, and 11, and 7, because they are very commonly associated with diseases in the baby. Some of the diseases, very interestingly, can resolve themselves. For instance, trisomy 8, if you have uniparental disomy from the mother of trisomy 8, they often have diabetes at birth, neonatal diabetes, but they can recover after that as time goes on. Next, please. And next. So you can also, as we talked about, doing just smaller changes, not the whole chromosome. And deletions and duplications, as we well know, can be associated with intellectual disability as well as some birth defects. But if you do the traditional screening, like an ultrasound, most of the time you do not see anything on these children at all. And the same with the biochemistry again, you don't find anything. So it can be quite a shock at the end. The mother says, why did you not find a problem? Next. And again, there's been many, many papers now that have been done. And so we are finding these quite well with NIPT. And we are finding that many are confirmed in the fetus when we combine everything up to 53%, but some of the studies are finding a very high number are confirmed in the fetus, up to 75%. Next, please. Oops, we've done that one. I think it's gone the other way. Thank you. And down again, and down, and down. So let's talk about what do we do as genetic counselors? How do we talk to our women about this? And of course, whether you do expanded NIPT or the common trisomies, it's always important to note this is a screening test. It is not diagnostic. The biggest reason it's not diagnostic is because of that placenta. We're testing the placenta, not the baby. This is a good part of NIPT. We're not harming the baby in any way. There is no risk. But it's important to note this means we can also the result may not reflect the baby, okay? And it is limited to the specific things that we are looking for. We are not going to find thalassemia if we're not looking for thalassemia, okay? No test is 100%, even an amniocentesis. Many of these babies, as I'll show you in some cases, their amniocentesis was fine because we were examining the skin cells and the urine cells. We can't examine the brain cells on an amniocentesis or even the heart cells. Next, please. So we've talked about mosaicism, but actually there's other reasons that you could get an unexpected result on NIPT. The mother actually may have a condition herself. She may have received an organ transplant. Most of the time, we only find this is an issue with reporting the sex of the baby. I had a case, we said the baby was a boy. When they did the ultrasound, they said, no, this baby cannot be a boy. And then when we asked more questions, the mother had had a kidney transplant. It was from a male donor, and we were getting the cell-free DNA from that kidney. Remember, in all of our cell-free DNA, all of our organs are releasing cell-free DNA all the time, okay? We can actually also pick up cancer, malignancy in the mothers. This is not a test for cancer itself, but we are finding it by accident. This is often good because we find it very early and can protect the mother. Sometimes there were twins and one of the twins has died, but the placenta has remained, so we continue to see that result for some time. And there can be, the mother might have chromosome changes. We like to think we all have perfect chromosomes, right? But we do not. We all have little changes. And so sometimes you just find a change in the mother. She is well and healthy. It has caused her no bother. Next, please. So, of course, in the pre-test counselling, you need to understand what is the mother's history, her medical history, previous pregnancy history. Has she lost pregnancies before, had children with some problems? What's her family history? Maybe this is her first pregnancy, but maybe her mother or her husband's mother had many miscarriages. Has she had any carrier testing? Do we know if she's a carrier of thalassemia or something else? And of course, talking through the benefits and the limitations of these testing. And then what would this couple like to know? Sometimes the doctor says, why would we do a test like this? Because they're not going to do anything about it. They'll continue the pregnancy and just have the baby at the end. Why know ahead of time? I have many, many patients who say to me, I want to know if my baby has a problem so that I have time in my pregnancy to grieve, be worried, and then be happy and welcome my baby with joy. I want my extended family to be able to welcome my baby with joy, not sadness. And also to arrange where should I have this baby, which hospital is best for me and my baby for the best start in life. Next, please. Of course, post-test counselling, even after a normal result, you can't just say, oh, it's fine, off you go. You need to reassure, of course, that we were just looking for certain things. Ultrasound is still important. Still keeping up with the medical checks are important. Next, please. But what if you get an increased chance result and it's for one of these unusual chromosomes? What do you do? Generally, the guidelines say you should offer invasive testing, chorionic villus sampling or amniocentesis, but not every woman wants to do that because there is a risk of miscarriage with those tests. So sometimes we find in Australia, the woman says, okay, I know there is a higher chance that my baby will have what you said on NIPT. At the end, we will test the baby and look at the baby. I don't want to do anything more right now. And obviously other things you need to consider is how far pregnant she already is, what's her previous history. In our country, we will do NIPT really until 36, 37, 38 weeks, right to the end. In case, if we're suddenly worried about the baby, it gives us a little bit of information. We might need to be more cautious at the birth. Next, please. But also, there's now many, many, many papers that can help you with your counselling. They tell you exactly which chromosome is the ones you need to worry about. Which ones are the one that may be associated with an increased chance of miscarriage even after 12 weeks? Which are the ones that are more associated with congenital anomalies? Often these congenital anomalies can be fixed. It may be a cleft lip or palate we can do something about. IUGR is the growth restriction as the pregnancy goes on. There are things sometimes we can do for that, but certainly watching closely, newborn death or uniparental disomy. So you do at least know the information and which pregnancy should watch closely and which just to watch the birth closely. Next, please. Next, thank you. So I thought I'd talk through some of the patients that I have seen, and please let me know how I'm going for time. So this was a lady that she was 39 weeks pregnant, 39 years of age. She was in her second pregnancy. She had NIPT at 11 weeks and it said trisomy 4. Now, initially we would say trisomy 4, that can't be in the baby, can it? We don't see lots of children with trisomy 4. So she had an amniocentesis because she wanted to prepare. It said there was nothing wrong. She had an ultrasound at 20 weeks with a very very high professor and his equipment, nothing wrong. But I had been working with this professor on many of these cases and said, I think you should watch this pregnancy. What if it's in the placenta? What if it's real? Let's watch closely. And he had also learnt, he had seen a few cases himself where the pregnancy started to go quite badly. So he said, I'm going to bring this lady back for an ultrasound at 29 weeks. Let's just check on how the baby is growing. I have no concerns, but let's check. At 29 weeks on the ultrasound, the professor noticed that the placenta was no longer working. It had what we call absent and reverse end diastolic flow. So this baby was in serious trouble. So they did an emergency cesarean section right then, took the lady straight down to deliver the baby. The baby was delivered this 10 weeks early and was in intensive care for 10 weeks, but was absolutely well and healthy otherwise. When they looked at the placenta, all of the placenta had trisomy 4. And this was the reason that she got into trouble at 29 weeks. The baby was quite small when it was born. And the professor rang very excited and he said, I think we saved this baby's life. If we didn't know about this, this baby would have been an unexplained stillborn. But we saved this baby. This baby is still well and healthy, is now 5 years old. Next, please. Thank you. So this lady had first she had, I think you call here the double test. She had an ultrasound and a blood test, and it said, oh, there's a high chance of trisomy 21. And so she said, I'd like to look at NIPT. What does NIPT say? And it said, no, not Down syndrome, not trisomy 21, it's trisomy 16. So when they did the follow-up ultrasound at 15 weeks, they said, this baby is fine, it's growing well, and we can't see any problems. Next, please. But the amniocentesis actually said, this is true. Actually, the amniocentesis shows some cells with no chromosome change, some cells with trisomy 15. By the time she got to 20 weeks, in fact, they found the placenta was small because remember, it has the chromosome change. The baby had small kidneys and a heart defect, so it took a long time to show itself. Next, please. So in this case, it was confirmed, and initially things were falsely reassuring. But this baby went on to do well as well. Next, please. Yeah, you can click a few times. So this was another case where the individual had NIPT because they were thought to be a high-risk pregnancy. The NIPT said, this is trisomy 9. The patient said, I don't want to do anything further. I'm scared of a miscarriage. Let's see what happens. The ultrasound found that there was a bright spot in the heart. Sometimes this indicates there might be a heart defect, but it's very hard to see. How many have you done an ultrasound before? Have you seen an ultrasound at 18 weeks? No. Do you know how big the heart is? The size of your thumbnail. So tiny. It's very hard to see if there is a hole in the heart or a problem in the heart at 18 or 20 weeks, so it can be missed. This baby also was little. Next, please. So the baby was born spontaneously at 37 weeks. It was small, under 2 kilos. It had no problems. It looked quite well. And on the cord blood, the umbilical cord, they did find indeed that some trisomy 9 cells, some standard cells. We followed this baby, and at 1.5 years of age, this baby was not developing the way that we should, had not gained their milestones as we thought. This baby also couldn't breathe. It was dependent on oxygen, a permanent oxygen tube, and also could not suck and feed, so it required a tube feed. And the growth was not good, was quite small, and the way that the head had developed was a bit different as well. So just to show you that sometimes the NIPT was right all along. The baby didn't show any signs until they had an opportunity to grow more and we could watch them develop. Next, please. So again, just that very big reminder, developmental delay, intellectual disabilities, we cannot see that on ultrasound. There are no brain changes that are apparent. Next. Now, how do we go for time? I've just got a lot of cases, so we can stop at any time. Or ask any questions. Perhaps I'll do this case. This was trisomy 16. Trisomy 16 is very, very well known to be one that can cause pregnancy problems because the placenta does not work very well. So it's one that can cause preeclampsia, very high blood pressure in the mother, which can be lethal if not detected. So when we saw this result, we were worried about how this baby might grow. And in fact, this baby had very severe growth restriction early on. The amniocentesis said nothing is wrong, but we were still concerned. This mother went into premature labor just spontaneously at 35 weeks, again with a very small baby who had no problems, no abnormalities. And again, we found that the cord blood had no chromosome changes, but when we looked at the placenta and we were able to do biopsies of many parts of the placenta, it had different results. Some parts were 93% trisomy 16, some parts 44%, some parts 36%. So the placentas can be very, very mixed. Okay, and so just an important reminder, trisomy 16 is very commonly associated with intrauterine growth retardation. It can be so severe. I had one lady that unfortunately the growth restriction was so bad by the time she was 25 weeks, the baby could not survive the rest of the pregnancy. It was so little and not developing. Next. Maybe I should stop with the, okay, we'll do this last one because this was similar to the first one, but the opposite. Another one where the mother was thought to be high risk. They found trisomy 15 and again, no problems. This baby was well and healthy, but in fact, the amniocentesis, they did do the carrier type and a SNP array, and it was completely fine. This was a boy who did not have a chromosome change, but they did do the methylation studies because they wanted to check, knowing that this was chromosome 15, and this baby indeed did have Prader-Willi syndrome. And you might say, why find out at 20 weeks this baby will have Prader-Willi syndrome? Did you just cause the mother anxiety for another 4 months? Thank you. But actually, no, this was important for this mother to know. Often babies with Prader-Willi syndrome are in fact born quite small. Later, they become quite big, and they can have significant feeding problems. They might require a tube feed because they don't have the muscle strength to feed from the mother or even to feed from a bottle. So this lady was able to, in Australia, we have a big country and many of our hospitals they don't have like resuscitation or intensive care for our babies. So this lady was able to come to the right hospital so that when her baby was born, our pediatric team and the intensive care looked after the baby, could do the tube feeds and teach the mother. She met the pediatricians before the baby was born so that she could learn how to care for her baby. And we could make sure that was all in place before the birth. Had she had her baby in a country Australian hospital, it could be very serious. It might need like the air ambulance, the plane or the helicopter to take the baby to another hospital, and it could be injured in that time, a brain injury if it's not feeding or breathing very well. When they looked at the placenta, in fact, yes, it was confined placental mosaicism also for trisomy 15.
And then in the microarray analysis, you find maternal UPD, but the SNP is actually normal. So how do you know that the SNP has the UPD?
So the only reason you know the question for Prof. Sultana was, we said on the NIPT, it says trisomy 15, but the SNP array says fine. How do you know that it actually has uniparental disomy? The only way to know is because the recommendation is to do the methylation studies. So for certain chromosomes, even if the SNP array is normal, that you must do the methylation studies. Also remember that the NIPT, it's a different test. It's looking for extra chromosome material, extra DNA material. So it can, whilst there was trisomy 15 in the placenta, the baby did not have trisomy 15. It had undergone trisomic rescue. Correct. So Prof asked, would we do the methylation studies from amniocentesis? And yes, this is the answer. Even if the amniocentesis shows no problem, you go on to do methylation studies for the certain chromosomes, 15, 16, 27, and 11. So we were able to know ahead of time. Yeah. So I might stop there so we can take any more questions.
Yes. Yeah, only one question again. Yeah,
Great talk, Dr. Ellis. I'm a molecular biologist, so just a follow-up question from Prof. Sultana. When you do the methylation studies, I generally thought that you need lots of DNA because you need to do some bisulfite conversion. How do you do this methylation studies from a very small DNA? I mean, that is incredible. Thank you.
That's a very good question. So the amniocentesis, you're right. We generally collect around 15 milliliters of fluid, one small tube. It's not very much. The laboratory do try to replicate the DNA. So they culture it, they isolate it, and then they replicate it to make more and more DNA. Also for methylation studies, you do need the father and the mother. So sometimes this can be difficult. Sometimes the father can't come to the appointment because maybe he is working or something like this. But we do need the comparison of two parents as well as the fluid from the amniocentesis.
Is it
Correct. So you need, what the laboratory does is they almost put like a little colored flag. Maybe dad has blue and red and mother has pink and yellow. And then they follow that into the fluid to say, they put tags onto the chromosomes so that when they see it in the amniotic fluid, they can figure out which color flags does this have? Did both come from one parent or one from each? Yeah.
you know,
Thank you.
Oke, masih ada yang ingin bertanya? Boleh? Ya, Dr. Ariski ya.
Good morning. Test. Okay. I want to ask what pregnancy conditions that have the biggest risk that we can motivate or trigger the patient to do NIPT? Because in Indonesia, we can have it for free, so we have to be wisdom to motivate the patient to do this test. Thank you.
So this is a good question. The international guidelines say all women, young and older, should be offered NIPT. But in many countries, my country as well, the woman must pay for it. It's very, very expensive. She cannot get it for free. So this is very difficult. If we think about, so here I understand, like if it's called high risk pregnancy, maybe she could get the test for free, or maybe she's allowed to have the test. Usually we would say older women, maybe like 35 and above, or pregnancies if she's had maybe some miscarriages, or maybe she has a child already with a developmental delay. But in fact, what we're now learning is, for instance, if you find that the baby is small, like not growing very big, that actually would be a good reason to start looking. Is there a problem in the placenta? And the reason I say that is because even if she is already 25 weeks pregnant, you might say, why will we do that now? And I know it's not usually done in Indonesia, but if you check the NIPT and it shows one of these chromosome changes, it means, again, that we could watch the mother more closely. We may be able to offer her aspirin to help the placenta to work a little bit better. And we could also make sure that we watch more closely on ultrasound and seeing the doctor and go to the right hospital. So it can be helpful so that the baby does not die during the rest of the pregnancy.
Thank you very much.
Okay, thank you. Yeah, thanks, Kathy. Yeah, I think we have a limit of time, so thank you, Miss Kathy, for such enlightening and provoking presentation. Your expertise has truly enriched our understanding of non-invasive testing. So maybe with that, we come to the end of today's guest lecture event. Once again, thank you all for joining us, and we look to see you at future events. Thanks. Yeah. Yeah. Oke. Ya, mungkin teman-teman kita sekarang bersiap-siap ya ke SLB. So Katie, yeah, would like to join us to go to the SLB schools. Yes. Assalamualaikum warahmatullahi wabarakatuh. Terima kasih semuanya.